Welcome back to Weekend Prime, and today we are looking at the 2017 state of Kenyan health. And today in studio with me is Benson Biwott, who is the Secretary General of the Elgeyo Marakwet Kenya National Union of Nurses. And also we have Tekla Mutisia, who is a human rights activist, and Peterson Washira, who is the chair of the Kenya Union of Clinical Officers. And today we are looking at healthcare and what 2017 has been for the health of many Kenyans. And clearly, no one should have to choose between death and financial hardship. But unfortunately, that is the harsh reality for many Kenyans every so often. Dr. Tedros Ghebreyesus, the Director General of the World Health Organization, says it is completely unacceptable that half the world still lacks coverage for the most essential health services. Kenya is sadly in that category. Let's not forget that health is a right, and the Kenyan Constitution affirms it. The enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being without distinction of race, tribe, religion, political belief, economic or social condition. 2017 has in no doubt seen many Kenyans not enjoy that fundamental right due to the major strikes that paralyzed the public health sector. And the first strike was in December 2016, where the Kenya Medical Practitioners Dentist Union went on strike for 100 days that ended in March of 2017. Within that period also, we had the Kenya National Union of Nurses being on strike for 10 days. That's from December 5th to about December 14th in 2016. And they went back on another strike from June 5th of 2017 for 151 days, a strike that ended in November. The Kenya Union of Clinical Officers also went on strike for 21 days within the same period that the nurses were on strike. Now, during this period, many questions arose as to where Kenyans were seeking services during the strike. And according to statistics, 58.4% of Kenyans seek outpatient services from public health facilities. 17% of Kenyans seek from private facilities, 13.1% from chemists and pharmacies. These are Kenyans who go for over-the-counter prescription or over-the-counter self-diagnosis and self-treatment. And we have 11.5% who seek health facilities in other places like mission hospitals. Now, during the strike, many services were affected in the public health sector. And among them were the maternal or the maternity services, that's from antenatal to during delivery and post-delivery period. Now, children's vaccinations were also affected in some areas, and we know that vaccination for most of the children is free, but some mothers could not afford any other alternative when the nurses had closed the facilities and were no longer working during the 151 days. Emergency services were also affected, and of note is during the Karai incident in Naivasha, where there was a grisly road accident and the doctors were on strike, and many Kenyans could not seek services promptly that they needed at that time. Other outpatient services and clinics were also affected during the strikes, and these include the usual CCC clinics, and these are the comprehensive care centers which attend to patients living with HIV. Now, one of the major questions or the major discussions is, can Kenyans afford health services? And it's good to note that 1 in 5 Kenyans, that's about 17% of Kenyans, have health insurance, in which NHIF is the largest provider. Therefore, in a crisis situation like what we saw in 2017, when the public health sector had failed, 4 in 5 Kenyans, therefore, who needed health could not afford at that time, and they found themselves between a rock and a hard place. And as I said earlier, in studio I have 3 of the unionists and a human rights activist, and 2017 has seen Kenyans really suffer. 3/4 of the year, there has basically been no health care in Kenya. Your comments on this, and I'll start with you, Tekla.
3/4 of the year, there has not been any health care in the country. It was terrible. It was really, really bad. Because now when there's no health care, when this Mamamboga back there, because clearly I am meant to, okay, my understanding of the whole thing is that when we talk about Wanjiku, when we talk about Mamamboga, we only praise her when she has to vote. Yes, but after voting, no one cares what happens to her. Because now no one speaks about her when issues like healthcare now begin to rise. And when you go back to where that Mama Mboga is, that is where you can see so many quacks. Because they know she is not exposed. So once there is that strike, she'll opt to go to that dingy clinic and going with the belief that that is a doctor. And it's absolutely nothing. There's nothing. She's risking misdiagnosis. You know, she's actually even risking her very own health. Because she doesn't know what she wants to is just the medicine, and then she lives by the belief that she is going to be fine. And these people out there are just making money. Because like the system in Kenya right now, if you have the money, you can open up anything. So because these people, the owners of these places have the money, they come and open clinics back there to just extort these people's money without any technical know-how. And so by the time these people realize, by the time the patients realize it is really bad, that is when they'll be given the referrals, and by the time they're taken to the major hospitals, they're told it's too late. Yes.
Peterson,
yeah.
3 quarters of the year seen the public health sector its strike. She said that this was a time when people were actually taking advantage of those people who could not afford alternative health care. Your comments?
Yeah, I think my take is, and before I comment on this, I want to condole with the nursing fraternity and the family of Mwadila. That is the nurse who was shot by a patient, and also call upon our members of parliament to be able to look into the Firearms Act. And I hope we'll get a chance to discuss about this and how we can be able to remedy this situation. What I would like to say is I think the problem is with the leadership and governance. Because in our country, and if you look at the components that usually make a good health system that is efficient, leadership and governance must be very strong. But now we have a leadership and governance that portrays the unions, because the problem was between the health human resource through their unions and the leadership of the health sector. So the unions are seen to be like resistance movements without prejudice to anybody, where they are seen like they're enemies of service delivery. But I think we should come to a point where both the unions, us, and the government have to understand that we are supposed to work, both of us, for the stability of the health sector. But for that to happen, we must understand that the right of a Kenyan to receive health care under Article 43(1)(a), and the right of that worker to form a trade union, to have good working conditions, to have good remuneration, which is given in the Constitution, they must both meet somewhere. And for them to meet somewhere, then we must see this worker as the one who is going to deliver the services that have been guaranteed to a Kenyan by the Constitution, vis-a-vis their right to have a trade union and to have better working conditions, so that we can have an ongoing forum where these things are discussed, and we don't have to wait for a crisis, because we have become a country that only solves crises, so that it doesn't reach to that level of the crisis. We'll have sorted the issues, and then we can have stability in healthcare.
Benson.
Yes. Let me condole also with our nurses, because we lost 3 nurses last week. We lost a gentleman from Samburu County, another gentleman from Isiolo, and Mwadimi, who was shot by a patient. And we have 3 burials today. We also lost a clinical officer in Laikipia last week. So we have gone through very tough time this year. 2017 has been very tough for us. As a union, I must say that we are not enemies to the government. We are co-workers with the government. And the whole of 2017, most Kenyans did not receive essential services, because the reason was that we went on strike, and we didn't like to go on strike, but the government refused to negotiate with us and agree. And I think a major problem that we have in this country is devolution of health to the counties. And that is why we have a big problem. It was devolved, and they devolved only 25% of the resources were devolved. 85% remains in Afya House. We have quite which does not have more functions than the counties. Then if they devolve it, then they devolve with 100% resources to the counties, so that the counties can be able to pay the workers. But for this country to attain good health, it is very important that human resource in Ministry of Health should go back to national government under all circumstances. But now it will take us time to be able to do that, because it has to involve having a referendum, which may be very expensive. But the government can form an authority through an act of parliament that can report back only the human resource that can advise the government on issues of this.
But across sections of Kenya seem to think that devolving healthcare was actually a good idea, because they have seen some bit of improvement in some of the facilities that are closer home. Yet here you're saying it is the problem. Isn't it contradicting with what the Kenyan, whom Tekla is saying the Mamamboga really is talking about or is receiving on the ground?
For equality and for good service delivery, it must be run from one point. And it must be checked from one point, because doctors, clinical officers, nurses are trained by the national government. And they must have a good regulatory body that regulates these people, that posts these people to various places. You can find in a county, you don't have specialists. All the specialists are only in towns. But if you go to the periphery, there are no specialists. Go to places like Elgeyo Marakwet, we have very few specialists, the doctors. Reason being, most of the doctors run their clinics in town and they stay in town. But if you go back to where Mamamboga is, you cannot get obstetricians there. You cannot get physicians there. It's only the clinical officers who carry the burden and the nurses in this country. And that is why we are saying nurses and clinical officers must be remunerated well, so that, because they are the service providers in the Ministry of Health. Otherwise, even if we struggle so much, without a nurse being there, without a clinical officer being there, no service will be good. So otherwise, even devolving us or doing all these things, they must do it very well.
You've brought a point about the human resource being equitably distributed, and I'll just come back to it, because the Health Act 2017 has actually addressed that. But before that, I want to just hear your comments on the two of you on, is devolution the problem in healthcare? Tekla.
Devolution is not the problem in healthcare. As much as it may seem, these people who are doing all this, are they honest? Because if there's this devolution and everything is handed to where it's supposed to be, we wouldn't be having these problems. Why do we have to talk about devolution when the larger part of what we need remains in the office in Nairobi? What are we doing? If it's devolving the whole thing, let the whole thing go, let the whole package go. Yes, because I have these people at heart. Yes, but I don't have to just say, yes, there's devolution, and clearly there's nothing back there. We're just going around in circles. This devolution thing is just there for formality on papers. Yes. It is just there for formality, because we wouldn't be hearing all these cries. Yes, if it was real devolution, we wouldn't be hearing all these yells and cries and everything. Yes.
Peterson, is devolution the problem in healthcare?
Actually, I want to agree with her in saying that the idea of devolution is very good, because we are trying to take services closer to the people. And the problem has been with the implementation of the devolved healthcare system. Well, as he said, we devolved the health, and we say it's completely devolved. But actually, if you look at it, it's a part of it is devolved, and the other part remains in the national government. But then the other problem is that, as I was saying, like leadership and governance, it's their coordination. Because at some point, devolution has also become a problem, and in this way, that you find like now, where we are getting problems, especially with the health human resource, is that you find there are policies that have been made at the national level, but the counties are not willing to implement them. So if we can have coordination of all the components, if it's leadership, the leadership at the county and the leadership at the national government should not act as if they are exclusive. There should be a coordination mechanism, of which I believe is provided for in the Health Act 2017, of which still we need the goodwill of these people to be able to implement it, because we are very good at making very good documents, but we never implement them.
Yes, and it's actually the Kenya, the Kenya Health
Human
Resource Oversight Authority that's supposed to actually look at the human resource, the equitable distribution, and to make sure that the professionals, the consultants, and the specialists are distributed according to where they are needed. And this is also the issue of the interns comes in. And so my question is, will the Health Act 2017 and a component like that be a cure to some of the problems that we've seen this year? Peterson.
Yeah, that is going to depend on still the goodwill, because the problem is that the goodwill has been lacking. I don't think there is a clear understanding of the health system in this country. For us to be able to evaluate this, and so that we can marry it with the Health Act, I think we need to look at what are the components of healthcare. If we are talking about the leadership and governance, health financing. In health financing, there is already an Abuja declaration which said that we need at least 15% of budgetary allocation to go to health. In Kenya, that has not happened. And that is why the ratio of doctor to patient still remains about 9 per 100,000, while it's supposed to be about 40. For clinic officers, it's 12 per 100,000 when it's supposed to be 40 per 100,000. And more so for even the nurses. So because of the lack of finances, then the other component of health human resource, you find that, as I am saying, that we have very acute shortages. And why I'm saying there is no coordination between the national and county is because all this data exists. If you look at the Staffing Norms and Standards 2014, which is a document of Ministry of Health, they will tell you that by 2018 they needed to have 16,278 clinic officers in service. They only have 5,000. So we have a shortage of 11,000, and this is with the knowledge of the national government. We have a shortage of more than 11,000, I think, nurses. I think 10,000 for doctors. That is according to what they have projected themselves. As a follow-up to that, a member of parliament, in his own wisdom, because he had seen the suffering of Kenyans, is called David Ochieng. He took a motion to parliament, and it was passed, where they had said, they had passed that they should employ 5,000 clinic officers, 5,000 nurses, and 3,500 laboratory technicians immediately, and then 3,000 actually every year, until they're able to reach that point of satisfying the staffing norms and standards. Those are documents that have remained in the shelves of the national government. The counties are not implementing, and I don't know how we are going to reach there. If you are talking about service delivery, then all the other components must be okay, because service delivery is an equation of how is the leadership and governance? How is the health financing? Do we have enough finances for us to be able to procure medical equipment and even technology? And even to procure better methods of information systems? Are we able to hire enough, to recruit enough, and in the right mix? Because you understand that in the health sector, you cannot have one cadre running the facilities, as we have seen in some areas. You find nurses are the ones everywhere. They have been made to prescribe, to dispense. In some areas, they have also been given some random kits to be able to do the laboratory work. Well, actually, you can be able to bring in everyone so that you can have efficient service delivery. So the Kenya Health Human Resource Advisory Council, it can try to sort the problem. But then we still feel it lacks that power, because it's an advisory council. It can only advise. But then if we can be able to amend it so that it has the powers, we make it the body responsible for the healthy human resource. because it's an intergovernmental forum where you have people from the county and people from the national government. So if it can be given explicit powers, so that if it's the issues of transfer, whatever it gives out, because it will be giving out policies, then the counties cannot just decide to do away with the advice. Then I think at that level we can be able to sort this.
Okay. Be what?
I must say health services in Kenya is really going down. And we really have a acute shortage of nurses in this country. I've gone to several counties. I've visited around some counties, and you'll find in a ward of 30 patients, one nurse is manning the whole ward, whereby one nurse is supposed to nurse only 6 patients. So the shortage we have in this country is alarming. And from all indications, and from, for example, from my county, we are required to have 700 nurses to be able to, that is the minimum that we can work with comfortably. But at the moment, we only have 385. We have acute shortage of 300 nurses. And from indications that my governor is telling us is that they have no finances to even employ one nurse. And right at the moment, people are exceeding the service and no replacements. So
but the issue of, sorry to cut you short, the issue of shortage of the human resource for health, that is the doctors, the nurses, the clinical officers, the laboratory technicians, all the cadres, is a continuous song in the country. We've heard it time and again that, you know, we have shortage, yet we train every now and then. So where are all these people going? Are they leaving? Are we getting brain drain because of all the issues that we are facing in the health sector in the country?
Some people are leaving the country for greener pastures, which is good. It is also good to have that, people going to venture into other places. But we are training, and they are going to private sector. Many are going to private sector. In this country, we have about almost 45,000 nurses. In the public sector, we only have 26,000. That's a very little number compared to the number trained. And we train these people, they don't get jobs. So people venture into other businesses. Because if you are trained somebody, you don't post the person to other facilities, then how will these people reach the facilities? It is very tough because the government is not employing. That is why I'm saying, unless a solution is taken seriously, unless our government takes seriously issues of health, this country will go into problems. Yes.
Okay. Tekla, he's saying people we are training, they're going to the private sector, they're going for other greener pastures. Is the private sector in health costing the public sector where most people actually go to seek services from?
The private sector may not work like the public health sector. Yes. What I get from him and from Peterson and from Benson here is that there's something between this coordination. And so after training for all these years, I don't want to waste my time with running up and down, being lied to. Nothing is clear. You know, no one is coming out. No one is telling me something tangible. Let me do something else. Yes. Let me try and get something else to do. Yes. Because my understanding as per what they have said is there's a lot of, there's a divide. Yes. So, something is not coming out clean here. And not everybody is being brought on board. Yes, that is why there's that breakage. Yes. Someone wants to make a decision for, other people want to make a decision for other issues. And they don't know what it feels to be back there. Yes, that is the breakage. That's what I understand. So if, if I would be there, why not? I'd just run into the public sector. I don't want to waste time running around and striking and making noise and no one is listening to me. And like, there's something that you said, how many nurses? By 2018. And we still have a shortage of 11,000. How long are we from 2018?
It's just
yes. How many years was this one? So some of these documents are just shelf documents and in big boardrooms. Okay. Yes.
So I want us to take a break, and when we come back, we'll look at the political will and the governance, which is really a critical part of achieving proper healthcare, and we'll try and put a finger on where the